Hello, everyone. My name is Nathalie Jette, and I'm a professor of neurology and vice chair clinical research, also in neurology. I'm also chief of the Division of Health Outcomes and Knowledge Translation Research. I'm an epileptologist, but I'm also a health services researcher and neuroepidemiologist, and I'm really excited to speak to you today about health equity in the operating room. I'm going to focus as a neurologist. I'm going to focus on epilepsy as an example, and particularly talk to you about barriers and strategies to improve access to epilepsy surgery. So really excited to join this Thrive Fellowship program as a speaker. So I'm hope that by the end of this talk, you'll be able to define health inequities and disparities, and using epilepsy surgery as an example, discuss facilitators to epilepsy surgery, barriers to surgery, and propose strategies to improve access to epilepsy surgery. Many of these are applicable to other surgical interventions. So let's start with some definitions. Health disparities, many definitions exist. This is one that I like. It's essentially measurable differences in health status between population groups that are unfair and avoidable and are defined in the social, economic, demographic, and geographic terms. Health equity is the fair distribution of resources needed for health, fair access to opportunities for wellness, and fairness in the support offered to people who are sick. And healthcare disparities are the differences in the quality of healthcare that aren't due to access-related factors, clinical need, preferences, or appropriateness of intervention. So we can keep that in mind for the rest of the talk. This is a really great article published in the New England Journal of Medicine this year about understanding and mitigating health inequities. There are definitions, but I also like that it gives a great historical kind of timeline of publications and events related to health disparities and health equity in the US, starting all the way in 1985, when the Health and Human Services published Black and Minority Health, the first comprehensive federal report on race and health, all the way to 2010, when the Affordable Care Act became law, and then up to 2020 with the COVID-19 pandemic that really exposed significant racial and social factors, resulting in disparities in morbidity and mortality. This is a study from a couple of years now ago, looking at trends in health equity in the US, and they looked at the data by race, ethnicity, sex, and income. They used the BRFSS, or Behavioral Risk Factor Surveillance System data from 1993 to 2017 with more than 5.4 million respondents. And what they found is that the Black-white gap showed significant improvement, but measures of health equity and health justice actually declined over time. And they also found that this income disparities worsened. So although there has been progress, meaningful progress on health equity in the US will require much greater effort. And so a lot more work needs to be done. So how do we address health disparities and increase health equity? There are many solutions. I'm going to go through some examples with you of different things that can be done. It's important, first off, to really target manifestations of structural racism and address social and economic inequities. As in people who are studying to be healthcare providers or as healthcare providers, we often focus a bit more on education and but more on healthcare system initiatives. But it's important to know that in order to decrease health inequities, economic stability, neighborhood and physical environment, education, food, community safety, and social context have to be also considered. So it's important to really not just track adverse outcome and look at disparities in outcomes, but also intervene on what are the underlying drivers of these outcomes, including the personal and social factor, and what do we do about it. This is an example from Rutger, New Jersey Medical School, where they develop a pre-clerkship course really to empower future physicians to advocate for health equity. And it provides the various topics from, privilege and power, unconscious bias, racism and health, health literacy, all the way to stigma, physician advocacy, and so on. But it's a really great, curriculum that covers many, many important aspects and topic that can help make these learners better advocate for our health equity. The Affordable Care Act in 2010 also has helped to decrease the number of uninsured individuals in the US. You can see that the poor in blue and the non-poor in kind of a reddish dark pink has decreased over time, but still, even as of 2015, there were still 29 million people in the US who remained uninsured, and substantial inequalities still existed along economic, gender, and racial lines, as stated in this paper, and so still much work to be done. Other ways to decrease health inequity through value-based payment, by really using cross-cutting approaches to address health-related stigma, and also initiatives within hospitals, whether it's health policy and so on, to try to really make sure that those who are marginalized are have their needs addressed. And then particularly importantly for this this group is leveraging health informatics to foster, a better response to health disparity and health equity challenges. This is a great article that goes over various informatics domain, whether it's in the public health domain, population health, community health, consumer health, different sort of challenges that we face, such as how do you establish guidelines? How do you increase health literacy? How do you increase access to care and so on? And how can you do it using information technology, data source, and strategy? And as a health services researcher, these are a lot of the approaches that I use, using electronic patient portals, patient health records, electronic health records, health information exchanges, data warehouse registries, and so on, to try to, one, identify disparity, but to use these tools to reduce disparities in health. So I want to introduce you to a patient that I met in the past, 55-year-old right-hand dominant African-American man with epilepsy since age 15, poorly controlled on medication. He had already tried 7 anti-seizure medication, but was continuing to have weekly focal impaired awareness seizure. He couldn't complete high school because of the seizure, couldn't work, wasn't receiving social assistance, wasn't in a relationship, had poor psychosocial outcome. But EEG and MRI confirmed that he had right temporal lobe epilepsy. He was never told surgery may be an option. So this is someone who could have been seizure free for the past 20, 30 years, but surgery was never offered. Unfortunately, drug-resistant epilepsy is a fatal disease. It affects 1 in 3 people with epilepsy, and individuals with drug-resistant epilepsy have really high premature mortality. They can die of a sudden unexpected death in epilepsy. They can have cognitive decline and really have poor psychosocial outcomes. It's unfortunate because we know that epilepsy surgery is superior to medical management. There have been randomized control trials showing this, including a recent pediatric RCT. There have been hundreds of prospective cohort series. We have practice parameters and guidelines that have been published supporting epilepsy surgery over medical management in those who have ongoing disabling seizures that are not controlled by medication. This is one of them, the American Academy of Neurology guideline, published in 2003, a long time ago. Not only is epilepsy surgery superior to medical management, but although the workup is expensive, once somebody is successfully treated, then healthcare costs decline substantially. And that's been shown in many economic analysis. And yet delays to epilepsy surgery still exist. It takes on average 20 years from seizure onset to surgery for an adult, and about 10 years in children. And often it's not primary care physician that may not be referring, although they may not. But neurologists in many studies may even be less likely to refer than primary care physician. So there are many barriers and facilitators to epilepsy surgery. And I'm going to discuss some of these. In terms of facilitators, someone who's very disabled by their seizure, if they're frequent, severe, they're, affected by stigma because of their seizures and are suffering serious injuries or complications, will be more likely to want surgery. Many people want surgery because they want to be seizure-free so they can drive, work, have educational opportunities, be in a relationship, and so on. And newer, less invasive, both surgical therapies and diagnostic studies, such as, responsive neurostimulation, which we are really a leader in the country here, are really facilitating surgery because it's much less invasive. We had done some work looking at, other facilitators, and one of the questions was about whether patient families trust their healthcare providers, and 93% said yes. And so really we felt like, we were really privileged that they felt that way, and that it was really our responsibility to properly inform them about the benefits and risks of surgery, and also to this, remove misconceptions about epilepsy surgery so that they are properly informed and can make the decision to move forward when appropriate. We've written about other barriers to epilepsy surgery. They are patient and caregiver factors and physician and health system factors. Lack of knowledge and misconception is significant. Poor behaviors or cultural issues, access issues. We know that those who are older, non-white, who have a lower IQ are less likely to be operated, even though they are equally likely to be a good candidate in the right setting. Those insured by Medicaid usually have a longer time to surgery and are less likely to receive surgery than those with private insurance. So those are all other barriers to surgery. So other patient barriers is that they often consider epilepsy surgery to be very dangerous. So for example, they think of it as a last resort treatment. In one study, more than half of patients wouldn't consider surgery, even if it would stop, they knew that it would stop their seizures. In another study in Italy, 73% of patients felt epilepsy surgery should be a last resort measure, and we had similar finding in a Canadian study that we did. This is a US study, this time about the parent narrative of the journey to pediatric resective epilepsy surgery. And again, parents are very, very scared. They really are scared. They find it scary. They often think of it as a last resort option and are afraid to, they think it's very extreme. In a study that we did, administering questionnaire to patients to understand their attitude and behavior towards epilepsy surgery. When we ask how dangerous is epilepsy surgery in carefully selected patients, more than 50% said that it was very dangerous or moderately dangerous. And when we asked them, when we said brain surgery should be considered as a last resort, more than 50% strongly agree or somewhat agreed with that statement. In addition, when we ask in general, brain surgery for epilepsy is more dangerous than having seizures that are not controlled, not true. 1 in 3 said that they strongly agreed or somewhat agreed with that statement. So we went on to do many systematic reviews on epilepsy surgery outcomes, hoping to be able to educate people and dispel some of these misconceptions about the risks of epilepsy surgery. We thought that maybe if we can, look at the evidence, it will help reduce disparities by removing some of these misconceptions. So for example, we found that major medical complications occurred in only 1.5% of patients, and major neurologic, although 4.7%, most were reversible actually. So the risks are even lower nowadays with less invasive approaches. We also looked at social outcome and found that overall the majority of study reported improvement in social outcomes, same with psychiatric outcomes. other studies find other barriers to epilepsy surgery. So yes, one with neurologists is negative attitudes towards epilepsy surgery and their misconception about risk. So some of these systematic reviews and if you educational can help reduce this misconception. In one US study, more than 10% of neurologists had never discussed epilepsy surgery with their patient. This is many years after many of the surgical series had been published. In one Italian studies, more than 50% of pediatric neurologists didn't follow surgical recommendation. And in our Canadian study, questionnaire of patients, 22% had been discouraged from having epilepsy surgery, and 65% of the time neurologists were responsible for that decision or that recommendation. We did a large study, a large questionnaire to understand knowledge and attitudes towards epilepsy surgery. It was sent to every neurologist in Canada. And we had almost a 54% response rate, which is quite significant for a specialist survey. We found that over 45% of neurologists, and these were involved in the care of persons with epilepsy, were not aware of the American Academy of Neurology 2003 epilepsy surgery guideline. Now, we did our questionnaire back in 2013 or 14. So this is now 10 years after the publication of these guidelines. Also, a third of neurologists believed it should be a last resort measure. However, epilepsy surgery should be considered after someone is drug resistant. As soon as someone is drug resistant, which means they failed an adequate trial of 2 tolerated and appropriately chosen anti-seizure medication as monotherapy or in combination to achieve seizure freedom. So not after they've tried, 12 anti-seizure medication. The earlier we intervene, the better. There are also, I've talked about some of the patient barrier and caregiver barrier, provider barrier, and there are health system barriers. We know that, in many centers in the world, for those of you interested in global health, that there is poor access to epilepsy center. They don't even have neurologists or never mind neurosurgeon. There can be a lack of communication between tertiary epilepsy center and community-based practices. And we know that there are disparities in older people, minority population, and uninsured individuals. So what are strategies to improve epilepsy and surgery knowledge and referral? We've written a lot about this. This is an article we published in Lancet Neurology about surgical treatment for epilepsy, the potential gap between evidence and practice. And there's a lot in there, but as part of it, one of the things we provide are some strategies, possible strategies to reduce health inequities and increase access to epilepsy surgery. A lot of them are more technological, like online educational tool, webinar podcasts, online management tools, social media can really help. As you know, it can also harm. So you have to be careful, and stigma reduction interventions are huge, especially in low resource settings. But a lot of online tools can really help to dispel some of the myths and misconceptions if they come from reputable organizations. In North America, more than almost 94% of people have access to internet. So definitely a way to reach people. There are a lot of epilepsy lay organization, and they can really be helpful to dispel some of the myths about epilepsy surgery. This is an article looking at social media, and it was encouraging that they found, when they looked at over 403 posts and tweets, they found that almost 50% provided information about medication, or they corrected misconception in epilepsy, which is really great. But surgical intervention were only mentioned in 1% of all posts and tweets that they looked at. So very low mention. In terms of societal or community strategies, those are huge to address health inequity, particularly the advocacy group and lay patient organization can really help promote policy. They are amazing advocates, working with government and healthcare policy to establish anti-discrimination policy, in particular, improve public transportation at reduced cost for people with epilepsy, stigma reduction intervention, and so on are all important approaches. And physician strategies. So online educational tools, guidelines, especially electronic guidelines, tools that are embedded in the EMR, or screen prompts, or decision-making tools, or pay performance type models, mobile clinic telehealth, and so on. There are many ways to increase knowledge and implementation of best practices and reduce inequities among providers. Guidelines are big. We've written a lot about epilepsy to try to dispel some of the myths. This was an article about epilepsy surgery in the Canadian Medical Association Journal, kind of like the JAMA equivalent in Canada. We've also worked on establishing criteria for pediatric epilepsy surgery center. And because I'm interested in global health, I've also done work with the World Health Organization on developing guidelines for non-specialized health setting about epilepsy and even drug-resistant epilepsy. Unfortunately, guidelines take a long time to be implemented. This is, as you know, some of the randomized controlled trial for epilepsy surgery were published in 2001. Guidelines were published in 2003. So this is, they looked at, after the randomized controlled trial was published and some of the guidelines, and found that the time from seizure diagnosis and starting medical therapy to surgery did not change before or after the guideline. It was the same amount of time. So there have been a lot of studies trying to implement epilepsy surgery guidelines and so on. And unfortunately, it's still an elusive target. We're not doing a good job at implementing them. So we have to be more innovative. We know that clinical guidelines improve processes of care and clinical outcome. This is an old systematic review, but it's still the case. We also know, however, that computerized tools are better. They improve processes of care. They can also improve outcomes. So if the guidelines are implemented or incorporated into the EMR and at the point of care, that's really the best. Still to this day, this is an older article, but a newer one published, I believe, just in 2019. So how standardization of practice can improve outcomes. So if you standardize practices by using evidence-based guideline, incorporating into clinical practice, that you can really improve outcomes. And then clinical decision support, another way to reduce health inequity. So in 2016, AHRQ, or the Agency for Healthcare Research and Quality, launched CDS Connect as a public web-based platform for authoring and sharing CDS knowledge artifacts. So whoever was developing clinical decision support can share these, and this has been really helpful and has really helped some centers rapidly implement the clinical decision support internally. Other ways to reduce health inequity is again to improve knowledge. And so when I was younger, I was very interested to develop an online tool for non-specialists that would help them determine if someone should be referred for an epilepsy surgery evaluation. This was before the definition of drug-resistant epilepsy was published. And we didn't have that guidance to say once someone failed 2 meds, they should be referred. So we developed a tool using the RAN-UCLA appropriateness method, where every patient who would see someone, you could just fill out, answer 6 or 7 questions. So there were over 2,600 scenarios. We developed a website for it. People would answer 6 or 7 questions, and it would say, according to the cases criteria, your patient should be referred for an epilepsy surgery evaluation. In this case, the score was 9, and it gives a little summary of the questions that we asked. Our tool was actually implemented across a major initiative in Europe, Epilepsy, which is a pan-European project with the primary aim of improving the awareness and accessibility of surgery for epilepsy across different countries. It was translated in 12 languages. We did feasibility testing to see how easy was it to apply it. We tested its accuracy and did some validation using a large surgical cohort from Sweden with over 1,000 operated patients. We also did a mixed method study to see how do we implement it among primary care provider and other non-specialists. And colleagues at Harvard even used it to apply it recently in Bhutan to look at missed opportunities for epilepsy surgery. Other ways to increase health equity and reduce racial and ethnic disparities along the same line of what I've been telling you is really to standardize care by implementing quality measurements. So if you can, again, use the EMR to do quality measurements and make sure that things are standardized. This is a new effort and a recently published article showing that, that standardizing care by implementing quality measurement can help reduce racial and ethnic disparities. Other ways to reduce disparities using technology is, again, I've talked about the electronic medical record. We've developed validated case definition in our Mount Sinai Health System to identify those with epilepsy, and we're now able to look at various, different aspects of epilepsy, if people are getting the best care, and if not, how do we change that? We're validating now, we're just finishing a validation for status epilepticus and new onset refractory status epilepticus, also developing a case definition, and most importantly, these were using ICD codes and medication, but for drug-resistant epilepsy, the ICD codes are not ideal. So we are using also natural language processing to enhance a case definition so that we are able to identify people with drug-resistant epilepsy in our electronic medical records so that we can make sure that these people are referred to our comprehensive epilepsy program for an evaluation now and not 10 years from now. So this is an important way using the EMR and alerting their providers that if they have drug-resistant epilepsy, that they really, I think that, you have to implement policies in some of these instances to really make sure that these patients are evaluated so we can improve their health outcomes. And finally, our team has also been involved with some e-learning health system, also using EMRs for quality improvement, standardization of care, and so on to really try to reduce health inequities and so on. Finally, I've mentioned participatory action research. We've been really involved with that. We've developed some very brief learning module on PAR and really engaging key stakeholders, people in the communities, especially groups where there are significant disparities in minority populations and others in research is invaluable and can really help you understand what the barriers are to care and how can we improve their health outcomes. Finally, for those who are just starting and interested in racial and ethnic disparities and other disparities in care, you can always start by identifying an idea and using whether it's the Sinai electronic medical record or national databases like we did here in these cases, the National Readmission Database or the National Inpatient Sample or market scan data or Medicare data or so on. Many of these data sets are available to us here at Sinai and can help us understand what are some possible disparities and what can be done to improve them. Finally, one more example. This is not related to epilepsy surgery, but it is related to comprehensive epilepsy program care. This is something that can be done for many conditions, not just epilepsy, but we used our provincial data at the time when I was in Canada and linked it to our clinical data. And we were able to look at the association of levels of specialized care with risk of premature mortality in people with epilepsy. So we hypothesized that people followed an epilepsy program had more severe epilepsy and would have higher mortality. But in fact, that is not what we found. So after adjusting for age and sex and comorbidities and so on, social deprivation index and that sort of thing, we've actually found that this is over time, the cumulative hazard of mortality was lowest for those who were exposed to a comprehensive epilepsy program compared to those exposed to neurologist care. And then the highest hazard of mortality was in those unexposed to neurologic care, which was very surprising to us. But a similar paper was published for children just within a month, showing the same pattern, this time in the UK. So within a month in 2019. So in conclusion, I know that you're aware of this, that it's really important to reduce a misconception about the surgical intervention that you're interested in, or you know, that you're providing to your patient. And in order to reduce disparities and inequities, it's important to not only reduce misconception, but also increase collaboration with community provider, people living with your condition of interest, and other key stakeholders that have an important word to say in regards to this intervention and what the barriers, and help you understand the barriers and facilitators. Technology and social media play an important role in increasing access to many of the surgical intervention we provide, including epilepsy surgery. And I know for us in epilepsy, it's really important to create linkages with government official, health system leader, policymakers, stigma experts. Stigma is a huge deterrent to surgery in epilepsy and the workup and so on, to ensure that policies are in place to protect minority populations, in our case with epilepsy. So these are just some of the individuals I'd like to thank who were involved when we developed our online tool, which now has to be updated, but you can see many of the participants and collaborators, those who provided letters across the country, the funding agencies, and then of course I couldn't do all the things I do without my team. So these are all the students and coordinators, and then many of my collaborators and mentors who have helped over the years. So just to finish, just to remind you that knowing is not enough, we must apply. Willing is not enough, we must do. We can do studies and confirm that there are disparities or inequities, but ultimately it's what we do next that is even more important. You know, how do we remove these inequities, and how do we address disparities, and what interventions are needed to address them? That's the most important, and all of you are doing important work in this area, including improving the technology we have and the approaches that we have to provide better care in a less invasive way, and so on. So thank you for your attention.